Hi everybody, welcome to Sincere Healthcare Group Facebook live stream. And today we have our Prof and Dr. Patricia Ko. So Prof and Dr. Patricia Ko, do you mind to maybe do a self-introduction to our audience?
Okay, I'm Dr. Patricia Ko. I'm a medical oncologist practicing at Mount Elizabeth Novena Hospital. I've been an oncologist for more than 25 years, and I do subspecialize in breast, lung, and gastrointestinal cancers. And I do see a fair number of young female patients. So I think this topic would be very pertinent to my patients.
Thank you, Patricia. I'm S.C. Ng, Professor Ng. I am in charge of the Sincere IVF Center, and we have been treating patients for fertility preservation as well, both for patients who have cancer as well as patients who do not have cancer. Of course, we are only concentrating on patients with cancer today. Yes, thank you. Yes.
Okay, thank you, Prof. And Dr. Patricia for your introduction. So, okay, for today's Facebook Live topic, we are actually mainly focused on the fertility and cancer. So, Prof. and Dr. Patricia, maybe can you share with us that the type of treatment affected the type of fertility preservation option that a patient will have?
So yes, in a way, the treatment and cancer type does cost me a lot, cost me to refer patients for fertility preservation. So the type of patients that I would generally refer to Prof would be the patients, young female patients who haven't had started a family and who may be undergoing chemotherapy treatment or even radiation treatment, depending on the location of the cancer. So many a times would be, for example, breast cancer patients, early breast cancer patients who require chemotherapy, or patients with lymphoma. So in this case, patients with lymphoma, there'll be male patients as well who would fall into this group. And again, we would discuss with them fertility preservation options such as semen collections. But in general, for females, they are more complicated. And therefore, these patients, I would definitely refer to fertility specialists like Prof. Ng for them to discuss which is the best options that they may have. So I'll pass to Prof.
Thank you. Thank you. I would like to just continue on what Dr. Patricia has mentioned. For the male, of course, it's relatively easy. If he can produce a semen sample, we will just freeze the semen sample. And normally we collect as many samples as possible before the treatment is initiated. For the female, it's a bit more complicated because of the physiology of the production of the eggs. So the eggs in the female is produced only once a month. So if we have the time, then of course we can initiate the hormone treatment to get the eggs to develop, and then we just collect only the eggs. Of course, when you collect the eggs, we also collect the cells around the eggs, which are known as granulosa cells. For the patients who do not have time, what we do is we collect the part of the ovarian tissue itself. So the what we call the ovarian cortex. So we do a laparoscopy, a keyhole surgery, remove part of the surface of the ovary, and then our embryologist would treat would mince them into small pieces and freeze them so that we have these tissues. So in terms of the what we do with that will vary. Of course, with the ovarian tissue, you need to put the ovarian tissue back into the body. And for cancers that have a possibility of the cancer cells being left in the ovarian tissue, there's a risk that you may reintroduce the cancer again. So that is a bit risky. For the eggs, then of course you can only do IVF because the eggs can then be fertilized outside the body. Embryos are created and then we put the embryos back. So it's an IVF procedure for egg collection, and for ovarian tissue collection, it is a return of the ovarian tissue back into the body. Thank you.
Okay, so can I ask that what happens if, let's say, if a patient is fertile before the cancer treatment start?
Yes, the patient can do a quick check for her fertility status. And for the female, this is very easy. You just need to do a blood test for this hormone called AMH, or anti-Mullerian hormone, and that will give us a quick idea. For the male, of course, I think the easiest is just to get a semen sample and then we will check. So of course, usually when patients diagnosed with cancer, they are highly stressed. So whether or not they're able to produce the sample, particularly for the male, also can be a problem. But the issue really is time, whether or not we can have the luxury of time to do the initial checks. But whatever it is, even if the fertility potential is low, you have to go ahead to do the necessary freezing of the tissues, because and that, I suppose, is the crux of the problem. No, they want fertility, and if it is the fertility potential low, all the more necessary why you should initiate the treatment.
Okay, so what should a patient make a fertility preservation decision right now?
Yes. Okay. I think most patients, particularly when they're young or who have the potential of starting a family later on, would definitely want to consider what is the future beyond cure, because once a patient is cured, then the rest of the fertility and etc. will feature into their life. Of course, if the patient's cancer is very severe, then whether or not he or she will make it also may play a role in her decision. Yeah. So maybe Patricia can talk about this.
Yes. And I think that's as Prof said, the stage of the cancer will make would influence a patient's decision as to whether they want to make a fertility preservation decision at the time of presentation. For example, if it's a very early stage, I would definitely discuss this with them, especially if they don't have a family as yet. Also, some of the chemotherapy drugs can cause permanent damage to the ovaries. Not all, certain ones. And in that case, then it will be even more pertinent to have that kind of discussion with the patient, because if it's an irreversible damage to the ovaries, and as Prof said, after the cancer is cured, they may want to start a family, and very rightly so. They should, because they should continue with their lives as per normal persons. Yeah. So I think it's very important that before they start a cancer treatment, for the young women or males who hasn't had who doesn't have a family to seriously consider doing so.
So is there anything that can be done during cancer treatment to protect patients' fertility?
Okay. All right. So for the female, there have been a few approaches. One approach has been to sort of keep the ovaries quiet in a way that, so there are what we call GnRH agonists, where you can put the patient into like a postmenopausal state. This was the work of Alan Townsend from Monash University long time ago, where the hypothesis is that if you keep the ovaries quiet, hopefully the damage to the oocytes a bit less. And this seems to have been borne out by some studies that look at these sort of patients subsequently. So I think there is a possibility. Of course, it also depends on the type. Long time ago, where they used a lot of radiotherapy, where you used to shine the X-rays into, or the radiation to the pelvis, then there has been surgical procedures where you try to lift the ovaries out of the pelvis into a higher areas. So there are these sort of approaches that may be possible, but obviously the best way is really to remove the gonads from the body before the chemotherapeutic agent or the radiation is initiated. Yes. Would you like to add something?
No, I think I agree with Prof that I think now there are many newer methods that have been proven to be efficient or improved. So I think those methods are probably best explored.
Okay, and for how long it is safe to delay patients' cancer treatment?
I think this is very controversial, and I think it depends on the patient's condition, the stage of the cancer. So it differs from patient to patient. Let's take the more common patients that I refer for fertility preservation. So those would be, for example, breast cancer women who are going to start what we call adjuvant treatment. So post-surgery, we're giving treatment to prevent the recurrence of the cancer. In this case, usually we would start chemotherapy 3 or 4 weeks after surgery, but we can delay to as long as 6 to 8 weeks. And I think what Prof will correct me if I'm wrong, you would need at least a cycle to collect sufficient eggs. So that would probably be sufficient time usually for the patients to collect sufficient good quality eggs. And for males, for example, for lymphoma cases or germ cell cancers, we can delay for a couple of weeks for repeated sperm analysis specimens to be collected. So usually we have no issue in trying to work with our fertility specialists to try and collect sufficient eggs or sperms for our patients. Prof?
Thank you. For the male, of course, is the need for the male to produce a semen sample, and we have had instances where, because of the stress and the fact that they are still in the hospital, they need to collect in the hospital environment, there were difficulties in producing the sample. Under this sort of circumstances, there is a procedure called electroejaculation, where you need to put the patient under anesthesia and you need to apply electrical probe into the anus to stimulate the prostate and the seminal vesicles. This is a electroejaculation technique which is used actually for paraplegics, for patients who cannot produce a sample for fertility. So this can be used, but this is not common. For the female, previously to stimulate the ovaries, you need to wait for the menses. But this has been shown not to be so critical. We can now initiate the ovarian stimulation any time of the cycle. Say, for instance, a woman is on the 3rd week of her menstrual cycle and found to have diagnosed to have cancer. Then you previously you need to wait another week for the menses to come before you can start the stimulation. But now the consensus is just go ahead to do the treatment, and you can just collect eggs at any time of the cycle. So it's still fine. It's just that the stimulation needs about 2 weeks before the eggs are mature. So there's going to be a delay for about 2 weeks. Yes, thank you.
Okay, so we're having treatment to preserve patient fertility if her cancer or if their cancer treatment, and if it is so, right, what are the effect could this have on the patient chance of recovering from cancer?
So for early stage cancers, if you're giving treatment to prevent the cancer from coming back, then I don't think that it doesn't. Treatment to preserve the patient's fertility wouldn't have an effect on their chance of recovery. It should not have any effect. There's a few cases where patients have advanced stage cancers and really want to have this option. Then in certain cases, if the cancer was very advanced, then sometimes it can have an effect on the cancer getting worse within that time. This is not usually what I would recommend, but I guess if it's a patient's choice, then we will have to counsel them if that's what they want to do. Yeah.
Yes, I would agree with Dr. Patricia. I suppose in the principle in the treatment here really is to ensure that the patient gets a cure from her treatment for cancer, because fertility issues normally become important only after the patient is cured. Of course, in certain instances, especially for the need for continuation of the family line, sometimes posthumous continuation of fertility may be important, but that is really something for the family to decide. Yeah, but that usually refers to the male, and is much easier because then you just need to get the sperm and do an insemination of the wife.
Yes.
Yeah.
Okay, so how long will the fertility preservation take, and what will be the expected delay to starting patient's cancer treatment?
I think I let Tom answer
Okay,
that.
thank
Just
you.
that patient.
Thank you. Yes. Okay. So the treatment for us, the male is very easy. You just have at least one sample, so the delay is very minimal. For the female, if you just collect the ovarian tissue, maybe just a short delay of 1 or 2 days, because after the surgery, it's a keyhole surgery. Most times the patient can initiate the treatment almost within a day or two, so there's no problem. But if it is hormone stimulation to collect the eggs, you need maybe about 2 weeks before you can, because the 2 weeks to recover the eggs. Then after the eggs are recovered, then you can start the treatment. So there is this short delay. But once the gametes or the ovarian tissues are stored in the laboratory, they can be kept practically forever, you know. Of course, there's a biological sense, but legally we are not supposed to keep the tissues beyond what is necessary. So I'm afraid if the patient doesn't make it, for instance, it doesn't survive the cancer treatment, then I'm afraid that the tissue has to be taken back by the family so that they can deal with it in the right way. Yeah.
Okay, so what are the chances of patient being able to have their own children in the future?
I think, from a oncological point of view, post chemotherapy, it depends on what type of chemotherapy they've had. For example, some chemotherapy may not cause irreversible damage to the ovaries or to the spermatogenesis. So some patients do recover and can have their own children naturally after a few years. So usually we'll advise them to not conceive in the first 6 months to a year post chemotherapy, and after that, then they can try, if they want to, try and conceive naturally. Yeah.
Yes, I would agree. Hopefully the chemotherapy doesn't damage the gametes too much, and if that's the case, then the patients can have the possibility of a natural conception. So for the female, if the treatment results in what we call amenorrhea, that means the menses doesn't come. Hopefully after the treatment is over, given time, if the ovaries recover, the menses may come. So there's an indication that maybe the ovary has recovered, and there's a possibility then the patient may be able to get pregnant. For the male, I suppose the only way to note is really to do a semen count or semen analysis to see whether there's still sperm. But the fact that the gametes are able to be detected, or whether menses comes back, may be an indication, but not necessarily completely so, because the potential to give rise to a young depends on whether the DNA is really affected. Because if the DNA is affected, even though, for instance, the menses comes back or sperm is also seen, but if the DNA is really affected, also there will be problems. So then the patient may have to fall back on the frozen sample. So it's always good to have some samples frozen. Yeah.
I guess it depends on the age of the patients when they start, how healthy and how fertile, or how healthy their reproductive system is before they start. But in any case, usually for anyone where I think there's even a mild chance, a low possibility that they could have irreversible damage, I would still refer to a fertility specialist, because it is always the safest if you have a backup plan. Yeah.
Okay, so would using any fertility preservation option affect the chances of the cancer coming back?
Okay, all right. Okay, fertility preservation option. I suppose the treatment, the option for the female is just either egg collection or the ovarian tissue collection. So this will be just taught in the laboratory and called upon if needed. So I don't think, of course, if you take ovarian tissue and the ovarian tissue has got a bit of what you call metastasis, that means a seedling of cancers, then when you return back to the body, there's always the risk of reintroduction of the cancer back into the body. But beyond that, I don't really think so. And for the sperm, we don't think so. Of course, like what we were talking about, the germ cell tumors may be a problem, and because germ cells refer to the sperm, the testes, and to the ovaries. So there's always this small risk, I think, is but there have been many studies that look at cancer cells in such tissues. Of course, it's very very low. Yeah. Maybe you want to add something.
I guess the germ cell cancers usually actually they are very curable. So actually, if they can conceive naturally after that, I've seen many patients who are the males who have conceived successfully with no issue. I think because their chances of cure is so high. So probably not a huge issue, and that I don't think that any fertility preservation option would really affect the recurrence rates of the cancer. Yeah.
Okay, so we thank you, Prof. and Dr. Patricia for sharing with us about more on this fertility and cancer. And we thank you everyone for watching and follow our Facebook Live. And we will see you next time. Thank you.
Thank you very much.
Thank you very much.